When painkillers and other treatments don't work, special implants can help patients with chronic pain. So coming up, we're going to hear what a life-changing difference spinal cord stimulators provide. Good morning. I'm Alexis Del Cid in for Jessica Lovell, who's enjoying a much-needed day off. Welcome to the Morning Medical Update. Some people live in pain every single day. There are different ways to manage it. There's pills, injections, exercise, physical therapy. But when those don't work, some patients benefit from a special device implanted into their back. Today, we're hearing about the huge difference this implant has made in two people's lives. Here with me in the Dolph C. Simons Jr. Family Broadcast Studio is Dr. Christopher Lamb. Dr. Lamb is an interventional pain management doctor here at the University of Kansas Health System. Thank you for making time to join us this morning. One of your colleagues is also with us. Dr. Dawood Syed joins us virtually this morning. Dr. Syed is an interventional pain medicine doctor here at the University of Kansas Health System, as well as Dr. Syed, you are the Division Chief of Pain Management and the co-founder of the American Society of Pain and Neuroscience. A lot of credentials behind your name. Your business card is jam-packed with credentials. Thank you for being here. And we're also hoping to meet two patients who receive spinal cord stimulators to help pain. We're waiting on David Conway to join us. He had a doctor's appointment, so of course that comes first. But if he can jump on, we're going to get him. And we have Diana Prouty joining us remotely. Thank you for being here, Diana. We appreciate you taking the time to join us. Dr. Lamb, I want to start with you just on the basics. How does a spinal cord stimulator or an SCS work?
All right. Well, thanks for having me. Spinal cord stimulators are kind of this therapy that we're having now in this field called neuromodulation, which is kind of a field of science and medical treatment that we're calling electroceuticals. And basically, we're treating neuropathic pain through using electrical signals that hinder, change, or impair these signals that from reaching to the brain. Different devices use different waveforms, different modalities, but in essence, it's using electricity to alter how pain signals are sent to the brain.
It's fascinating that something like this can help so many people who really were feeling helpless for a while. It can be so depressing to have chronic pain. Both of our guests today, hopefully when we get David and Diana use the Evoke system. What about the Evoke system is different from other types of implants?
So that's a really good question. You know, spinal cord stimulation has been around since the 1980s. We've grown a lot from the days where it was a device implanted in the back connected to an external power source where you're not really mobile, to where we have these small implantable pulse generators where people can go anywhere, do most things. Throughout the years, there's different waveforms, and like I mentioned, there's different properties about each device that make them unique and may benefit different types of patients in different situations. What's special about this device is that I usually tell patients that this is a input-output device. And what do I mean by that? This is the first device available where you can measure how your nerves are responding to the signals that you're emitting. And so basically, when patients have this device, they measure a therapeutic threshold for them. They measure a minimal signal and a maximal signal. And the device is able to keep the amount of energy supplied to the spinal cord within that range to help treat their pain conditions. So it's kind of unique because when you move, they always teach us in anesthesia, and it's relevant in this situation. You have nerve tissue in the spinal cord. You have the spinal fluid, which allows the nerve tissue to move back and forth. But you also have a lot of things like connective tissue, fat, muscle. And when you change your positions, the physics of everything changes the contact of the device with your nerve tissue. And so how do you know you're treating that nerve with the appropriate amount of energy? This device allows you to maintain the amount of energy to be consistent despite your activity.
So cool. I want to bring Dr. Syed in, because Dr. Syed, we've interviewed other patients who use a remote control for their stimulator. In fact, we were thinking of one, Dr. Kat Adams. She's a doctor here now, so she wouldn't have made it through medical school without a spinal cord implant that she got here. Now, she said she uses a little remote control. She showed us. Do these Evoke systems also use a remote control?
Yeah, well, thanks for having me on as well. And I think Dr. Lamb did a wonderful job of kind of setting the stage. So Alexis, really, these do have a remote control. Probably the biggest difference between this Evoke system, and again, spinal cord stimulation systems have been around since 1967. They've just gone a renaissance in how we use them. I think probably the biggest way about this is that it is fully automated. So the goal with the Evoke system is for patients to not need their remote control at all. So the remote control is there. But ideally, the way that the stimulator works, because it auto-adjusts on the fly, it takes 4 million measurements a day on each patient of how the body is reacting to the signal that it's receiving, that electricity. So that is adjusting on a beat-by-beat minute. So patients don't really need the remote control. Again, so that's our goal with this, is that patients take the remote control and put it in their nightstand. The stimulator does everything. And I'm really excited that Diane has agreed to share her story, because there's some really specific things about the pain that she was experiencing, which I think made her the perfect candidate for this. And I think she'll probably be able to illustrate that even better.
I can't wait to get to you in just a minute, Diana. We're going to get to you in a second. I have one more question for Dr. Syed. That's how much time someone has to be in pain before they can try the spinal cord stimulator. I mean, if you're in excruciating pain, how many other things do you have to try before this is an option for you?
Yeah, when those of us that do pain management or interventional pain management, we don't really look at it that a patient has to, has to be in this many months or years of pain before we offer A, B, or C. We're really looking for the most effective treatment has the least amount of risk associated with it at that time. So typically, a lot of people are going to try things like physical therapy and, non-addictive pain medications. And then maybe move on to things like injections, because 80 to 85% of the time we can manage the pain with those types of more simple interventions. And oftentimes people really aren't ready for something like surgery to fix their pain. If we think surgery can be done without high risks and has a really high, degree of benefit for the patient, we'll probably move very quickly to that. The same with spinal cord stimulation. If I see someone in my clinic and I think, you know what, A, B, and C is really not going to even get you anywhere. It's just going to make you jump through unnecessary hoops. We're going to work very hard with the patient and their insurance plan to kind of move much quickly with that. But on average, most people have tried conservative measures for about 6 months before they move on to a spinal cord stimulator.
I want to bring Diana in. We want to hear your story. Specifically, how long were you in pain before you had this stimulator implanted, and what was the cause of your pain?
I was in pain for about a year, about 14 months actually, trying conservative measures and all those that Dr. Syed was talking about. The problem was I had no idea that it was my back. So, sorry about the phone. My symptoms were in my arm. What happened was I was having a dinner party, making my dinner table bigger, and it fell, and I tried to catch it. And that's when I started having pain in my shoulder and my elbow and my arm. And it just got worse and worse. And we tried all those things. So I finally had an EMG and looking at the spinal nerves. So that was helpful, because finally we found that it was a back problem, not an arm problem. So it just took a long time to figure it out.
So just to be clear, you had a problem in your back, but you weren't feeling the pain in your back? You were feeling it in your arm?
I was very severe. It was so bad I couldn't even write my name.
Wow.
And spent a lot of time on the couch with ice bags under my arm and the places that hurt. But finally, all the pieces started coming together. So there was a delay at even getting started. Once we started working with Dr. Syed, we tried the conservative measures. They did not work. And we pretty quickly moved into having the spinal cord stimulator placed. And I was very happy with how that turned out. It's a process. It takes a long time to do the adjustments so that it's really effective. And it's something that requires patience on the person who's getting it, from the person who's getting it. So
Go ahead. Oh, I was going to ask about something that you just said about how it took these adjustments and tweaks before it was just right. I'll ask you more about that in a second. Dr. Syed, how do you do that tweaking of the stimulator?
Yeah, so it's, it's kind of when you buy a brand new car, you want to get the seat adjusted just right. You want to get the mirror adjusted just right. You want to get everything just perfect. So then, subsequently, when you have that car 3 months down the road, you're just jumping right in. You may not even get your keys out of your pocket. So that's what we're doing when we talk about these newer spinal cord stimulators like Evoke. We're level setting at first. We're seeing, for Diana, where is she, we're really doing all these precise measurements, but, for her, how we're doing these is kind of wirelessly through a laptop computer that connects and communicates with the brain that we had implanted in her body. Essentially, it was the battery. It's called the internal pulse generator. And we do all these adjustments with her in the clinic. Some of them we do the day of the surgery. So when we implant the device, we put the wires where we think they need to go for her pain. But you can never be absolutely sure because obviously Diane had problems in her neck. So her nerves were shifted and all these kind of things. So during the surgery itself, we actually wake up the patient. It sounds, a little bit anxiety provoking for people, but it's at a comfortable point in the procedure. Everything is already in. And we gently wake them up and we turn the device on and we say, Diana, where do you feel this? And, we ask them if we could really get it in that general region of where her pain was, which was her in her arm. And we were able to do that there. But then after that, the first 3 months, we're really trying to adjust it, fine tune everything. Because, when she's up and she's making dinner, we want it to kind of be at a different setting. So we're finding all those different settings. So we do that all in the clinic and we do that kind of electronically, wirelessly. But it does take some time. But once we get it perfect, the patient really doesn't need to come back in for those unless there's some major change in the way the wires are or in their body.
And that's what I want to ask Diana is once you guys had that level perfect, how quickly did you start feeling relief? And how long has it been since you've had to go back in?
I'm kind of through with that. I go in for checkups at this point, but I had to go in fairly often during that process. And now I'm just living my life. I'm not hurting anymore. I'm functional. But I was really surprised that they didn't have to touch me with anything. I sat in there and they put a device near me and then they were able to look at what was going on and the reaction I was having. It was really quite amazing and
That's
easy.
What I love hearing. You're back to life. You're back to doing whatever you wanted to do pre-pain.
Yes.
Dr. Lamb, can you talk to us a little bit about any common denominators when it comes to this kind of pain? Are there common conditions that people have that makes them more prone to get a spinal cord stimulator?
So that's a good question. Spinal cord stimulators are available internationally, and there's kind of variations between covered diagnoses. In the U.S., commonly the most typical diagnoses people have are chronic radiculopathy or neuropathic pain. So pain of nerve origin. Sometimes people can have it from something called failed back syndrome, a condition where you have back or leg pain, neck or arm pain that exists, requiring you to get surgery and subsequently return after surgery that is due to nerve-related origin. Diane mentioned something very unique in that she had an EMG and all these other tests to confirm these, and that's kind of exactly what we're looking for when we're looking for indications for this. It's people with nerve-related pain that failed conservative treatment, medications, therapy, interventions, and that's when we start thinking about spinal cord stimulation.
It still strikes me that Diana thought it was an arm problem, but it was all able to be fixed by going to her back. Is that common?
So it's more common than you think. So when we kind of evaluate patients, talk with patients, kind of look through their history and imaging, a lot of times you associate back pain with back pathology. But if you think about the anatomy of everything, the brain is connected to the spinal cord, and then when the nerves leave the spinal cord, they're called spinal nerves. And these spinal nerves provide myotomal and dermatomal coverage for your body, meaning that if your L4 nerve, I always tell patients, if your L4 nerve is pinched, you may have back pain, but it may cause you to have pain in the distribution of where the L4 nerve usually provides sensation, which is typically back, buttock, lateral hip, anterior thigh, over the knee, down to the foot. And so when a nerve in the neck is pinched, it causes arm symptoms.
So Diana, did it cure your pain completely? Is it totally gone?
It is totally bearable when I have it. I do have breakthrough pains. It's interesting because I'm so comfortable that I get to the place where I sort of forget that I've had this problem and still have the problem, but it's being cared for with the electricity. And I will do things like help the people clear the tree limbs. And then I'm reminded that maybe I shouldn't do that. But
you feel so good, you jump right in and start doing it.
And that's what people do. They do well, and then they forget, and then they get back, and then they start doing well again because they know the concept. But yeah, I'm not totally pain-free, but and I am 81, so when one is 81, one has aches and pains. So I'm not related to this. So I can't say that, but I can say that my arm pain is definitely improved, and I would put it at overall about 80%.
Wow, that's remarkable. Dr. Syed, your life's work is helping people with pain. You're the co-founder of a national professional group, the American Society of Pain and Neuroscience. What inspired you to create that group and to just take this journey professionally?
Well, in a simple terms, it's stories like Diane's. I think that Diane's story is not very rare when you talk to just normal people. You talk to your aunts and uncles, your grandparents, and either they have a similar story or they know someone dealing with it. So the main reason when we decided to start the American Society of Pain and Neuroscience about 6 years ago was that we really wanted to, educate, starting in the United States, all our clinician colleagues on these advanced therapies. This space or, medical technology, it moves so fast that we really thought that there needed to be a new society of kind of innovative physicians and clinicians. We have scientists, PhDs, all working together and really kind of digesting the new technology that comes out there and then validating it for people through educational programs like our annual meetings. So doctors can come in, patients can come in and say, wow, okay, this society thinks that this is a legitimate therapy. They do think there's these limitations, A, B, and C. These are the right patients to put it in. These are the wrong patients to put it in. So we can help people digest that. Because for all of us just kind of working our day-to-day practice, it is hard to kind of digest all of this stuff. It all sounds great if you just listen to the marketing, but really when you get down and you have to read the scientific papers, it really kind of is where kind of the rubber meets the road. So, and that's why like a technology like the Saluda implant, the Evoke implant, is really unique. It was, when I was looking at the clinical work, this was developed by a scientist named John Parker in Australia, who helped develop the cochlear implant for the ear. And he used that same knowledge to kind of develop this device for the spinal cord. And it makes too much sense. You're like, wow, why haven't we done this before? And, I've been putting in spinal cord stimulators my whole career, which is almost 13 years right now. But I always wanted that feature there. What we were trying to do is have the patient kind of use it with the remote control and set it up and set it down, which is great, but, again, it's better if people can be like Diane and just come, like, I love the word that she said, sometimes I just forget that I have the pain. That's what you want people to say. When people have a spinal cord stimulator that they have to kind of constantly adjust, they know they have a tool to manage their pain, but I guarantee you none of them will ever forget that they have pain. They know they have pain because they have the remote there and they're turning it up and turning it down. When you get into that fully automated state that Diane is in now, she can get into the point where she forgets about it. Now, we have to kind of rein her in a little bit because, those tree branches were pretty heavy with this last storm. So that would hurt almost anyone's back. So there are some things that we need to kind of, set the expectations because, yeah, that disease state is still in her neck. We're just managing the pain. But that's why, we really don't want a stimulator that takes 100% of the pain away. I like the sweet spot of 80 to 90% reduction because she still knows if she goes a little bit past that, pain is also a protective thing. Our bodies give us that pain response of, whoa, you're doing too much. So she still has that. The stimulator will not evaporate that safety mechanism of pain.
We have a viewer that just wrote in, nice compliment. She wrote that Dr. Syed is my husband's doctor. He is terrific. I'll have to tell you her name off air because her husband hasn't signed a HIPAA form with us, so I can't say it on the air. But that's a really nice compliment. We get lots of comments and
I love those kind of questions. I love those kind of questions. Yeah, because I don't have to answer anything. Just smile.
Sure, and it makes you feel good. That's what you want to hear from people. It's so wonderful to hear testimonials like Diana's. We love when viewers send us questions, comments, anything. You can do that to us via email or YouTube or Facebook, or you can tweet us. We're everywhere. If you'd like to email us, we're the Medical News Network. All the links are right there on your screen. And we also want to take a quick break from this conversation to dive into another one, our COVID count with Dr. Dana Hawkinson.
Yeah.
Dr. Hawkinson is the Medical Director of Infection Prevention and Control. Morning.
Hi, back to COVID for a little bit here.
We like when you're here. We don't like talking about COVID, but we love having you with us for your expertise.
We have other topics too, yeah. So right now, COVID count is still low, although inching a little bit higher as far as active cases. We have 11 total, but 8 active, 1 of those in the ICU with severe illness, 0 on the ventilator. So hopefully we can decrease that a little bit. We saw at the end of last week it was kind of inching up just a little.
Right. We've been hearing reports about that. COVID numbers are still relatively low, and we have been turning our attention to other headlines, and you know about all of these headlines. In fact, there have been several stories about rabies this summer involving animals like foxes and bats, but even ones you didn't expect, like beavers. There's a girl outside in Atlanta whose family says she was attacked by a rabid beaver when she was swimming in a lake. That's scary. You don't want to be attacked by anything, but you just don't think you'll be attacked by anything in a lake. Dr. Hawkinson, okay, Kansas, we hopefully won't see too many of those cases. We have plenty of raccoons, possums, and foxes. Are you seeing rabies cases often? And then what do you do when someone comes in?
We don't see rabies cases often. And it kind of is a little bit apropos talking about rabies and the neuropathic pain and nerve stimulator, because we know rabies infects the nerves. So rabies does circulate around the United States, and I think it is good to understand we don't have many cases here in the United States, especially in the metro area in Missouri and Kansas, but we have to be on the lookout for it. That's why it is so vitally important to vaccinate your animals against rabies, and also understand that, as we are having climate change, as we are having higher populations and populations moving into areas where there were no people before, it is important to understand that you must be careful when you see wild animals, especially those animals that you talked about. Raccoons, foxes, possums, those animals that really seem to eat anything, especially other animals, those are the most at risk of having and transmitting rabies. So if you see a fox, and I know that there's a few foxes here in the metro area, if you see other animals, do not go up and pet them. If they bite you, it is vitally important to seek medical attention and let that medical team know exactly what happened. There is a treatment for rabies. You do have, at least a couple weeks to get that, but the sooner the better. And the treatment is not what we used to hear when we were kids about so many shots in your belly anymore. It's a simple 4-dose regimen. You get the vaccine in your shoulder just like you would any other vaccine. But it's vitally important that if you do get bit by a wild animal, to go seek medical attention and let them know exactly what happened so that you can get treated, because if you do not get treated, it is almost nearly 100% fatal disease. But luckily you do have that time, but the sooner the better to get evaluated.
Well, glad you're not seeing many cases like that.
Yeah, but I think we have to be on the lookout again. Just more animals out there, more animals coming into contact with humans, more animals living in these urban areas in our cities now. So just be aware of that. It is less likely to have those animals, those more kind of like plant-eating animals like squirrels or chipmunks. But certainly even they can get it, just as we saw. This beaver did get it, probably got bit by a rabid animal, and so just be aware of that when you are seeing that. Most importantly, get your animals, your cats, your dogs vaccinated, especially if they are spending time outside.
Thank you, Dr. Hawkinson. Want to ask our reporters if they have any questions today. And there are no reporters on the line, but we have plenty of questions from our community. So let's get straight to Yulin. Yulin has a question about the implant. Dr. Syed, I'll ask you about this one. Does the implant need to be charged?
Yes, great question. So there are spinal cord stimulators that are rechargeable or non-rechargeable. The Evoke system is a system that needs to be charged. Now, it just really depends on how much power a patient needs to control their pain, on how frequent that needs to be. I'll let Diane answer how frequent she needs to do. I think our average patient is usually charging the device about once a week.
Diana, are you charging it that often?
There's a charger, and then there's the remote. They work in tandem. But I just leave my charger plugged in all the time, and I will charge it fully probably every 5 to 7 days.
Okay.
And
what does it look like when you're charging yourself?
It looks like I'm sitting in a chair watching television with a paddle on my back. That's what it looks like.
That's pretty
It's
good.
not anything. It's not like connecting an IV or anything.
Right.
It's just laying.
Relaxing.
And I don't
watching
keep
TV.
my remote with me. I just get it set, and it lasts all week. So,
Dr. Lamb, how long does the actual stimulator last? Do these ever conk out and need to be replaced?
So that's a good question. So it kind of gets down to, what is that IPG? Because usually once these devices are placed, the leads that are sitting on top of the spinal cord themselves don't really need to be replaced. It's the actual battery. And so one of Dr. Syed's friends, national figure in pain medicine, Dr. Deer, wrote a paper about, I think it's about a year now, that kind of looked at basically Medicare database data about primary cell, which is non-rechargeable, and rechargeable batteries. And it ended up being that about 7.5 years is when you would need one of these devices replaced. Interestingly, with the advent of new battery technology, that number could probably go farther out. But based on the data that they showed, it's about 7.5 years.
Yen Liang has a really interesting question. Yen would like to know, can we cut off our nerve? Can you cut off the nerve to completely kill the pain? Dr. Syed?
Yeah, very interesting question. The answer is yes and no. It depends on the nerve. So if you think about this very simply, we have all sorts of nerves in our body. When you think about the nerves for pain, we have nerves that are purely sensory. So all they do is feel. But then we have mixed nerves that are both sensory, but also they have a function, like they operate your arm or they operate your leg. So for instance, say if Diane's pain was only in her neck, there is a nerve there that we could cut, or typically what we do is we apply radio frequency lesioning through a small needle because it's much easier to do. And that could be very effective. And I believe we might have even done that on Diane and helped with some of her neck pain, but it didn't touch her arm pain. The problem with the arm pain is that it's one of those nerves that I described that's mixed. It has a function and it also feels. So if you cut that nerve, there's a chance that we could improve her pain, but there's probably a way too big of a trade-off in that her arm would not function like she wanted it to. So that's the problem there. So most people, pain is a bad thing, but if you take away the function, there's, that's something people, really, physicians or patients really aren't willing to accept. So that's why electrical stimulation is a perfect option for that, because it can treat both sensory and the functional nerve pain without removing the function. Actually, most people function actually increases quite a bit because the pain actually decreases your function, and we can get rid of that part of it.
I want to bring our whole panel in for today's takeaways, and I want to start with Diana. What's the one thing you want people to know who are watching?
I want you to know it's good to be back, to be able to do the things I like to do and want to do, to be social. I couldn't even go out sometimes because it hurt so bad, or I'd go out and I'd have to come home. So that's wonderful. Another thing I'd like for people to know is that the staff at KU, Dr. Syed, the interns, residents, I don't know what we call them now, everybody, and the people that regulate the device were wonderful. And you always have phone numbers that you can call people. So I'm thrilled. I feel so grateful. So I'm going to compliment
Dr. Lamb. Oh, sorry, I'm stepping over you because of our little bit of a delay. I want to ask Dr. Lamb, what's it like to hear compliments like that from other patients?
I think it's great. I think, a long time ago when pain medicine in itself was a new field, you always think of pain as another vital sign, but at the end of the day, you got to remember pain is a symptom. In our field, it's kind of unique because we're treating a symptom. It's great that we have options now to manage these types of pains that even a decade or two ago we would have no options for. And I think this device just kind of touches on the fact that technology, knowledge has advanced at such a pace that pain conditions, that were untreatable or currently untreatable can be treated in the future.
Dr. Syed, it must feel incredible to see such success for something you're so passionate about.
Yeah, it's great. First I feel very, humbled, and from the comments of Diane, our interventional pain team at the University of Kansas has now grown to, 11 double board certified physicians. We have 5 nurse practitioners. So it does take a team. When we're trying to do really advanced technological procedures in patients that have complex medical problems, an organization like our health system is the perfect place. We can kind of assimilate that technology and bring it to use for our patients very quickly, because I can tell you this Evoke system was not available anywhere else in the country commercially when Diane had access to it. That's one of the advantages coming to our health system. But really, I think the technology continues to advance. I just tell everyone to continue to be advocates for themselves or their family member. Just going into a pain management or a surgeon's office a couple years ago or even a year ago and saying, we have nothing to offer you, things change very quickly. And I may have had that same answer for Diane, 3 years ago. Like, I don't think a stimulator is going to work. I usually didn't really like putting stimulators in people in their necks, because if they moved their head one way or the other, they would get electrocuted. They would get strong stimulation. And you can see Diane right now in the video. She's moving her neck back and forth, and she looks like she saw a smile on her face, because it's the beauty of that automated system that she had. That Evoke Saluda system is essentially doing this on the microsecond level. It almost knows before she's going to turn that physiological signal is changing, so it's turning down the volume. So it's not, turning there's a siren going off right now here in New York City. And I can't turn it down, but Diane can do it with that system she has. So really wonderful thoughts here. And thanks everyone for your opportunity to kind of share her story and our story with us.
We need the Evoke system when there's background noise and we're interviewing people. That would be brilliant. If you can invent that, patent it, you'd make millions of dollars. Thank you so much for being here, Dr. Syed, Dr. Lamb, Diana. We just don't want to see you. If anyone sees Diana out lifting tree limbs, pull over and tell her to stop. We want you to protect your back. Thank you so much to our viewers as well for being with us today. We will see you right back here on Wednesday.
Coming up Wednesday on Open Mics with Dr. Stites. The world practically stopped in order to fight COVID-19, but long COVID isn't getting the same attention or funding. I'm Jessica Lovell on the next Open Mics with Dr. Stites. It's Show Me the Science, with the doctors defining long COVID, how they decide which symptoms do and don't apply. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.